Today we shall be discussing bone marrow transplantation. Now, the term has been replaced by hematopoietic stem cell transplantation after it has been discovered that the stem cells can also be obtained from the peripheral blood and the umbilical cord and not just from the bone marrow. What actually bone marrow is, it is a soft spongy tissue which is present in the large bones and it harbors the stem cells. While the stem cells are those immature cells present in the bone marrow that are giving rise to all our blood cells, the white blood cells, the red blood cells, and the platelets. So there are the three sites from which bone marrow could be taken. First is from the bone, second is the peripheral blood, and third is the umbilical cord. What are the characteristics of the hematopoietic stem cells? So that they are used in this bone marrow transplantation. They have a remarkable regenerative capacity. They could be cryopreserved, hence could be used later on. They have the ability to home the marrow space following some intravenous injections, and this process is mediated through the interaction between the receptors which are present on both the stromal cells and the stem cells. They have even the ability to survive freeze and thawing process which is involved for the transplantation. Now the characteristic of umbilical cord stem cells, they have very high concentration of the hematopoietic cells, and various side effects of the transplantation includes graft versus host disease, which is very low by umbilical cord stem cell transplants. These cells are rapidly available and they have decreased immune reactivity in an individual. Just minor side effect is the peripheral count recovery after the transplantation is slower in case the cells are transplanted from the umbilical cord. There are two categories of hematopoietic stem cell transplant: the allogenic transplant and the autologous transplant. Allogenic transplant. The word allo means other, that is, we are involving a donor and a recipient who are not genetically identical. While autologous transplant, the word auto means self, that is, removal and storage of the patient's self stem cells with some process and then re-infused. But the same individual receives some doses of myeloablative therapy to achieve immunosuppression in the individual. As the graft is from some non-genetically identical individual, in allogenic transplant, there is a high risk of graft versus host disease or graft rejection. The percentage of rejection or graft versus host disease will depend upon the relationship between the patient and the donor and even the anatomic source from where the stem cell is taken. While in case of autologous transplant, there is no risk of graft rejection or graft versus host disease. In allogenic transplantation, there is no risk of contamination by the tumor cells, while if some cells are left in the process of transplantation, they can result in the contamination with the tumor cells and leading to the relapse in case of autologous transplantation. The figure depicts the transplant process. In case of allogenic transplant, there is a donor and a patient which are genetically not identical. The stem cells are taken from the donor, maybe either from the umbilical cord, peripheral blood, or from the bone. Then they are processed to purify and concentrate. Thirdly, they could be cryopreserved so that they could be used later on. Then the chemotherapy dose of chemotherapy or radiotherapy is given in high doses to the patient to achieve immunosuppression. After this, these processed stem cells are reinfused into the patient. In case of autologous transplant, the stem cells are collected from the patient. They are processed and concentrated. Even they could be cryopreserved. High-dose chemotherapy or radiotherapy given to the same individual, and the processed stem cells are reinfused into the same patient. That depicts autologous transplant. Starting with the transplant procedure, it consists of 5 steps. Firstly, conditioning, followed by stem cell infusion, neutropenic phase, engraftment phase, and then immune reconstitution. Dealing with the steps, what is conditioning? It is done by the chemotherapy and radiotherapy. This achieves immunosuppression, hence our graft could not be rejected. It even creates a new space for the cells so that new stem cells could proliferate and regenerate, and even to eliminate malignancy. This phase lasts for 7 to 10 days. Second phase is the stem cell infusion and the processing. Infusion is done for 20 minutes to 1 hour, and it depends upon what amount of volume is infused. This processing of the stem cells leads on to the depletion of the T cells, hence there is a decreased graft versus host disease. Many patients during this process have the side effects of nausea and vomiting, which occurs because of the cryoprotectant used to cryopreserve the stem cells, like dimethyl sulfoxide. Then the patient achieves a phase of neutropenic phase, which lasts for 2 to 4 weeks, in which the patient is actually having no effective immune system and hence predisposed to many infections, for which empirical antibiotic therapy remains the mainstay of the treatment. In the engraftment phase lasts for several days to weeks, where the healing process has started in an individual. Now the cells are produced from these transplanted stem cells. They come in the peripheral blood, and hence fever and infections begins to clear off. Last phase is the immune reconstitution of an individual, which take months to years. The survival and the expansion of the donor T cells is the major mechanism for the T cells recovery, and B cell recovery takes place in 6 to 9 months, depending upon whether it is autologous or allogenic transplant. Immune recovery occurs rapidly after the autologous transplant, then the allogenic transplant. Uses of the bone marrow transplantation could be divided into non-cancerous conditions and cancerous conditions. The non-cancerous conditions include aplastic anemia, hemoglobinopathies like thalassemia, sickle cell anemia, and immunodeficiency disorders. The cancerous conditions include leukemias, either acute or chronic, lymphomas, myeloproliferative and myelodysplasia disorders, and multiple myeloma. There are several complications of bone marrow transplantations. They could be categorized into 4. The chemoradiotoxicities, which could be early or late, the graft failure, graft versus host disease, and the infections. Most common causes are the gram-positive bacteria, fungus, mostly aspergillus, and virus, which is mainly cytomegalovirus. Starting with direct chemoradiotoxicities, their early manifestations include the patient will be having nausea and vomiting, oral involvement in form of mucositis, and neutropenia, thrombocytopenias are common. Another important condition which occurs is SOS, sinusoidal obstruction syndrome of the liver, which clinically could be characterized by tender hepatomegaly, ascites, and jaundice in an individual. Even the individual starts suffering from pneumonia. The cause may be bacterial or may be idiopathic. Other infections within the blood may be bacterial, viral, or fungal. To enlist the late complications caused by chemoradiotoxicities is mainly in the lung, where they could be broadly divided as cryptogenic organizing pneumonia and bronchiolitis obliterans. Cryptogenic organizing pneumonia is restrictive disease, while this is an obstructive lung disease. Cryptogenic part, the person is characterized by dry cough, shortness of breath, while in case of bronchiolitis obliterans, the patient is having cough with progressive dyspnea. In restrictive lung disease, there will be diffuse infiltrate on the chest X-ray, while there is air trapping noted in cases of bronchiolitis obliterans. When the biopsy is taken, the granulation tissue is noted in the alveoli in cryptogenic organizing pneumonia, while it is present around the bronchial structures in bronchiolitis obliterans. The condition is completely reversible, the cryptogenic organizing pneumonia, while it is complete reversal is yet to be known in case of bronchiolitis. Treatment part is the steroids for cryptogenic one, while we have to achieve immunosuppression to decrease bronchiolitis obliterans. Moving on to the second main complication, the graft failure. Occasionally the marrow functions either does not return, or even after a brief period of engraftment, the function of marrow is lost, is called as graft failure. When the transplantation is autologous, that is from the self individual, the cause may be inadequate stem cells at transplant, or the cells are damaged during the treatment or storage part, or there is exposure to the myelotoxic agents after the transplant. While the causes of graft failure in the allogenic transplant could be due to the rejection of the immunological reaction by the immunocompetent host cells. Treatment of the graft failure could be by a short trial of the myeloid growth factors and removing all the myelotoxic agents from the patient's regime. Last of all is the graft versus host disease, which could be acute and chronic. Acute, which is occurring within the first 3 months of the transplant, which is characterized by maculopapular rash, diarrhea, and serum bilirubin levels are raised. That is, the three most systems involved are the skin, the GI tract, and the hepatic system. Treatment of the conditions include the calcium urine inhibitors, that is the cyclosporine or tacrolimus. They could be combined with anti-metabolite drugs like methotrexate or mycophenolate after the transplant. Even there are some studies where the role of anti-T cell immunoglobulin is added and is giving good results. Now there are 4 stages of graft versus host disease, where there are different rate of involvement of skin, liver, and the GIT tract. When the rash is less than 25%, 25 to 50%, then generalized edema, and then bulle formation. They're graded as 1, 2, 3, and 4 respectively for skin. Similarly, the serum bilirubin levels are 2 to 3, 3 to 6, 6 to 15, and more than 15 for stages 1, 2, 3, and 4 respectively. In cases of diarrhea, when the amount is 500 to 1000 ml per day, it is stage 1. For stage 2, it is 1000 to 1500 ml. More than 1500 ml is stage 3, and even the ileus part is involved is the stage 4. Now, chronic graft versus host disease. Its duration is between 3 months to 2 years of the allogenic transplant. It more commonly noticed in cases of old age patients or those having an episode of acute graft versus host disease, or the recipients are of unmatched stem cells. The patient is characterized by some features of autoimmune disorders like malar rash, Zika syndrome, arthritis. In lung, there is obliterative bronchiolitis, cholestasis, or bile duct degeneration. The treatment part in cases of mild cases is by local therapy, that is, topical application of steroids to the skin and cyclosporine eye drops. For severe cases, systemic steroids are used alone or may be used in combination with cyclosporins. Thank you.